afternoon, everyone. I'm Dr. Yaseen, Assistant Professor, Department of Emergency Medicine. So my topic of discussion today is refractory ventricular arrhythmias or electrical storm. So we'll define the topic, we'll discuss the incidents, management strategies, role of delayed ganglion block, and some review of the literature. So what is refractory ventricular arrhythmias? How do we define it? The other term is electrical storm. The definition is occurrence of 3 or more episodes of ventricular tachycardia or fibrillation within 24 hours. Sustained ventricular tachycardia or fibrillation refractory to 3 or more shocks and 3 or more therapies for ventricular tachyarrhythmias, that is anti-tachycardia pacing or shock within 24 hours if the patient is with ICD, that is implantable defibrillator. So coming to the incidence, according to the various studies, the incidence varies from 20%, from 4% to the 20%, and the exact incidence of the electrical storm is not known. It depends upon the various things, like if the patient is in cardiac arrest, then the incidence of electrical storm is different than that of patient with ICT in CT. So there are common triggers for the electrical storm. These are acute ischemic attack, mu are the worsened underlying heart failure, electrolyte disturbance like hypo or hyperkalemia, hypomagnesemia is another important cause, thyrotoxicosis, QT prolongation, and drug toxicity. The management part, as we know, the ACLS protocol for the ventricular cardiac arrest. As far as the stable tachyarrhythmia is concerned in stable electrical storm, which is defined typically 3 or more episodes of VT in 24 hours, the management is to identify the underlying cause, synchronize cardioversion, and if the patient is refractory, then along with the treating the underlying cause, you can increase the level of cardioversion, addition of antiarrhythmic drug, and cardiology consultation in the emergency department. If the patient is in cardiac arrest, you have to start the CPR and identify the rhythm. After the rhythm identification, you need to, after giving the 2 shock, that is as we usually do in the shock absorb rhythms, you will keep the aminoderm or lidocaine, whatever is available with you. The dose is initially bolus of 300 mg or 1 to 1.5 mg per kg of the lidocaine. Then we start the pathway, initiation the pathway for other drugs beyond ACLS, that is we can go for the stellate ganglion block or the use of beta blocker in the patient in cardiac arrest with electrical storm. So initiation pathway is 3 or more episodes of ventricular tachycardia, refractory to defibrillation, and refractory to the drugs. Initially you gave 300 milligram of aminoderm or 1.1 mg per kg infusion. You will start after that, and if the patient still has refractory electrical storm, refractory to these procedures, then after defibrillation and drugs, then next you will go for the beta blockers. You give Esmol 0.5 mg per kg bolus followed by 0.05 mg per kg infusion, and if the patient is still refractory, then you can go for the stellate ganglion block. Now, what is the evidence for the stellate ganglion block in patient with refractory ventricular arrhythmias or electrical storm? So the mechanism of action is cardiac sympathetic blockade, reducing the sympathetic surge and adrenergic tone. It also shorten the QTC interval in the patient with MI and prolonged QT syndromes. There are so many studies which has defined some role of stellate ganglion block in the emergency department in patient with electrical storm. So far we only have case reports and case series there, and some there is no meta-analysis, no large cohort study or randomized control trial to establish the effect of stellate ganglion blocking refractory ventricular arrhythmias. One study from Nademi et al. It is an RCT of just 49 patients in which he has shown a marked superiority of sympathetic blockade when compared to the standard ACLS therapy alone. Then there is another study from Fidem et al. In 2017. It is a systemic review where he has accumulated 35 cases published over the last 22 years, and the episode with stellate ganglion block was associated with reduction in RVA burden, that is refractive ventricular arrhythmias burden. Another study by Meng et al., again a systemic review, SGP is effective acute treatment in electrical storm, and 80% of the patient survived to discharge. That is something very interesting according to Meng et al. And Dime et al. Gave another study in 2019 which has shown that stellate ganglion block inhibits electrical storm in greater than 50% of the patient, and there were no procedure-related complication. And another study by Fidem et al. In 2020 which has shown that stellate ganglion block was effective in all patients with refractory ventricular arrhythmias or electrical storm. So coming to the conclusion, this was the first time a study case was presented by us when we reported ultrasound guided stellate ganglion block in a patient with cardiac arrest with electrical storm, where we do the stellate ganglion block, left stellate ganglion block, and patient was survived, and patient has good neurological outcome at the discharge. So now, what is the procedure of stellate ganglion block in the patient with cardiac arrest and in patient with refractive ventricular arrhythmia in cardiac arrest? So as we know, during the CPR, with ongoing CPR, we cannot perform the procedure, when there are so many vital structure in the neck. So what we did, we performed ultrasound guided stellate ganglion block in a patient in cardiac arrest. During the 2 cycles of the CPR, we placed the the linear probe, the high frequency probe at the level of the neck, at the cricoid cartilage level. Then along the ultrasound guided, we inserted the needle from the left side of the neck and directed towards the stellate ganglion block, where we inserted 2% of 10 ml of plate again. And that was all. That is how you can, and then another modality, it is something beyond ACLS you can use in the patient with refractive ventricular arrhythmia or electrical storm. So that is all. Thank you so much. This was a brief discussion to the stellate ganglion block and the refractive ventricular arrhythmia, which is something as of now not recommended by the ACLS guideline, but you can do in your patient with refractive ventricular arrhythmias. So thank you so much.